Okay, so we're going to begin the exam. This is my fiance Vivian. She's kindly volunteered. Don't mind the mess. We're cleaning up a little bit and rearranging. Just want to show you really quick my instruments, a couple of animals in the house, and there's nobody else in here, nothing that could possibly indicate cheating. So I'm going to place the camera over here and try to get the best possible visual feel so that you can see everything, Professor Levy. I'm first going to walk in the room. I'm going to introduce myself. Hey, I'm Kyle Piazza. I'm a PA student. How are you today? Good. Okay, awesome. So I'm going to wash my hands first, make sure I'm nice and clean. I'm going to get the patient's permission. Do I have your permission to do the physical exam?
Yes.
Okay, awesome. So at this point, I'm going to give the patient the gown. I'm going to give her a little privacy, tell her how to put it on, then give her privacy, come back, make sure she's decent, and we're going to begin the exam. I'm going to start off by doing the vitals. First, I'm going to take your temperature. Open your mouth, please. And while I'm taking her temperature, just keep it down tight. I'm going to take her pulse bilaterally. I have a watch on so I can time it. 15 seconds on the radial pulse. Pulse is 64. Now I'm going to do respirations. Okay. 5 and 15 seconds, so respirations are 20. Bring her up down. We're still waiting to hear that thermometer go off. So in the meantime, I'm going to just make sure the blood pressure cuff fits first. Hold your arm out, your left arm out, please. So the cuff is 40% of the width of her arm, and there's our thermometer, 98.6, perfect. Okay, now we're going to put the cuff on. It already fits 40% of the width. Now we're just going to make sure the circumference, hold these, please. We're going to make sure the circumference is normal. The artery is lined up, and it is about 2.5 centimeters above the antecubital region. The arm is free of clothing. So we're good there, thank you. I'm going to clip this meter on here just to make sure that it doesn't fall off and so we can get a nice good reading there. First I'm going to estimate our systolic pressure by palpating the radial pulse. So radial pulse stops around 110, so I'm going to inflate it to about 140 so we can eliminate that oscillatory gap. Now I'm going to take her blood pressure and I'm going to listen for the Korsakoff sounds over the brachial artery. I'm going to auscultate that artery, and I'm going to take her blood pressure here, get a good reading. Make sure that's good. I'm holding her arm at heart level. I'm going to deflate it slowly, 2 to 3 millimeters of mercury a second to get a good reading. Okay, 102/68. Take the cuff, remove it. Normally, if it's a new patient, you're going to take the blood pressure bilaterally. You also would take it supine because that's a new patient. The only vital we have left is BMI, which is body mass index. We're going to take her weight and height, and then we're going to take her weight in pounds, multiply it by 700, and then divide it by her height in inches squared. Her general appearance, patient appears to be about a young female, about 30 years old, well-nourished. Her affect looks like she's in a good mood, well-nourished, and no signs of distress. She appears alert and oriented. We're going to go ahead with the exam of the skin. First thing, we're going to observe the scalp, make sure that the hair distribution is normal. Hair distribution looks normal, pigmented very nicely. The skin is pigmented very nicely. No lesions, discoloration, edema, abnormalities. We can also palpate for edema. We can palpate the entire body. We would obviously check the toenails also, but here we're going to check the fingernails. We're going to check the skin for moisture, temperature, and turgor. Skin's warm, moist, and we're going to check for tenting bilaterally. So pinch her skin a little bit, it goes right back down. She's well hydrated, there's no tenting. We're going to check the nail beds for any discoloration or anything abnormal. We're going to check capillary refill in the nails by blanching them. Color returns almost immediately, so capillary refill is normal. Next, we're going to go for, also there's no clubbing on her fingers. I did check for clubbing. We're going to go forward with the examination of the head. First, I'm going to examine the shape. It's normal, cephalic, symmetrical, and atraumatic. Next thing I'm going to do is palpate her scalp too and the skull for any abnormalities or bumps. Take a nice look all around. Doesn't appear to be anything wrong there. The next thing we're going to do is check cranial nerve number 5, the trigeminal nerve. We're going to do the sharp dull sensation test with this Q-tip. I'm going to take either the sharp or dull end and have her tell me what she feels. Close your eyes, please. So I'm going to test the ophthalmic branch. Tell me if it's sharp or dull.
Dull.
Okay, now we're going to test the maxillary branch. Sharp or dull?
Sharp. Sharp.
Okay, now we're going to test the mandibular branch.
Dull. Dull.
Excellent. Now I'm going to palpate the masseters. Clench your teeth. Okay, when she clenches her teeth, I can feel the masseters are strong bilaterally. We're going to check cranial nerve number 7, the facial nerve. Smile for me. Frown. Puff your cheeks up. Raise your eyebrows. Close your eyes tightly and try to keep them closed while I try to open them. Okay. Cranial nerve number 7, the facial nerve is intact. The next thing we're going to do is we're going to go forward with the eye exam. First we're going to check the external. First we're going to do cranial nerve number 2. We're going to test the optic nerve first. Here's my Snell and eye chart. It says to stand about 6 feet away, but I'm going to stand about here because I don't want to get cut off in the field of view of the camera. So I'm going to have you read the first. Can you see the bottom line there? Okay, so cover up your right eye. Try to read the bottom line.
DEFPOTEC.
Okay, cover up the right eye. The other eye.
DEFPOTEC.
Both?
DEFPOTEC.
Okay, so vision is 20/20. Next, we're going to assess her visual fields via confrontation. I'm going to stand close. Just keep looking right here, straight ahead. And we're going to do the wiggle finger test. Tell me when you see my fingers moving into your field of vision.
No.
Okay, now we're going to test the middle field of vision.
No.
Okay, and lower visual field. Tell me when you see the fingers moving.
No.
Okay, now we're going to go ahead and we're going to test cranial nerves 3, 4, and 6, the oculomotor, trochlear, and abducens, respectively. We're going to do the directional gaze test, so I want you to just follow my fingertip. Okay, 3, 4, and 6 are normal. Now we're going to test for lid lag and convergence. Follow my fingertip. Lid lag and convergence. There's no lid lag and convergence. Normal. Now we're going to observe the external structures of the eye. We're going to observe the eyebrows, which the hair distribution is normal. They're symmetrical. The upper eyelids touch the iris and not the pupils, which is normal. Palpable fissures are of equal length. I'm going to take my pen light. I'm just going to observe the conjunctiva, which are normal, nice and pink on each side. The patient isn't comfortable with this, so I'm not going to do it, but normally we would check the upper conjunctiva by gently pulling her eyelashes and then push it down with the throat tongue depressor just to check the upper ones. The cornea is free of opacities, the sclera is white, the iris and the pupil appear to be normal color, no opacities or lesions. We're going to check the anterior chamber of the eye from the sides, no lesions or shadowing of the iris. Normal. We're going to check the corneal reflex by taking a soft piece of cotton, just gently touch it to each eye, but we're not going to do that because we don't want to irritate the eye of the patient. And that tests cranial nerve 5, the trigeminal reflex, or the corneal reflex rather, on the trigeminal nerve. We are also going to palpate the lacrimal ducts. Tell me if you feel any pain or tenderness.
No.
Okay, lacrimal sacs as well. And ducts?
No.
Okay, I'm sorry, these are the lacrimal glands. These are the ducts and the sacs. Close your eyes. I'm going to test for intraocular pressure. Feel any pain, tenderness?
No.
Okay, excellent. So that's normal. We're also going to test for visual, pupillary, direct, and consensual light accommodation. So first, I'm going to start with her left eye, and when I shine the light on it, the pupil should constrict, which it does. On the right side, it does as well. Direct accommodation is normal. Now we're going to do consensual. So when I shine the light in her left eye, the right pupil should constrict as well, and it does. And vice versa. and the pupils are normal size. They're both about 4 centimeters, which is normal, and they're equal rather than reactive. Next thing I'm going to do is do the cover test, which I'm just going to, this test for alignment of the eyes, so I'm going to cover up one eye at a time, just keep looking straight ahead. And once I remove the cover, if there's any abnormal movement, that indicates that's an abnormality, but there's not on that side. And same on that side, she's good to go. Now we're going to do the fundoscopic exam, for which the room has to be darkened. I'm going to use the ophthalmoscope. I'm going to stand in front of her. I'm going to keep it about 15 inches away from her eyes, 15 degrees laterally from her field of vision. I'm going to start out here, just keep looking ahead at a point. So I'm going to get in nice and close. I'm going to appreciate the red reflex, the optic disc, and the retina, which I can see the optic disc, as well as the arteries and the veins. And the same thing here, red reflex, arteries, veins, optic disc. You can see the optic disc right at the end if you come up a little bit, kind of look down into the eye. I believe that's everything for the eye. Now we're going to go ahead with the ears. I'm going to visually inspect the ears first. They're symmetrical. The pinna, the auricle, the tragus, the mastoid process all appear to be normal. I'm going to check the external auditory meatus for anything, discharge or lesions, any abnormalities, which I don't see. I'm going to palpate the auricle, the pinna, the tragus for any lesions. Do you feel pain or anything?
No.
Abnormalities? Okay, excellent. Now that that's normal, we're going to do the otoscopic exam. We're going to have a nice look inside of her ears and see if we can see any of the internal structures. We're going to use a nice clean piece here. So we're going to take a look first at what I'm going to do is get a nice comfortable pivot point about 20 degrees anterior of the vertical plane. And I'm going to take a nice look in there. I'm going to appreciate the tympanic membrane, the malleus, the umbo, the cone of light. External auditory meatus is clear, not too much wax in there. And the same thing on this side. External auditory meatus is clear, tympanic membrane, malleus, cone of light, and the umbo, all normal. I'm going to put a clean head on this because we're going to need it for the nasal, for the nose next. Now we're going to test cranial nerve number 8, vestibulocochlear nerve. The first thing I'm going to do is, hopefully you can see me here, I'm going to stand behind the patient and I'm just going to have her tell me if you can hear this.
Yes.
Tell me if you can hear this.
Yes.
Okay, now I'm going to do the whisper test, so I'm going to stand right here, repeat what I say.
AB1. CD2. EF3.
Okay, excellent. So her hearing is normal. If there were any abnormalities, we would conduct the Weber test, which uses a tuning fork to test for lateralization. Just tell me whether you hear it more in either ear or if it's even in both.
It's even.
And at this time, we would perform the Rene test. This test for whether it's neurosensory versus bone conduction loss. So I'm going to place the tip of the tuning fork against her mastoid process and tell me when you hear the ringing stop.
Now.
You still hear it?
Yes.
Okay, so even when I take it away, she still hears it after that, which indicates that air conduction time is greater, which is a normal finding. Because we're short on time, I'm not going to do it bilaterally, but normally you would. We would also test for insufflation in the ear by just gently putting a little puff of air in there, which we're not going to do because we don't have the proper tools to do it. Now we see we got ears, now we're going to do the nose. First, I'm just going to externally observe the nose for alignment. Look straight ahead, please. Septum's in line, doesn't look like she's ever had a broken nose. I'm going to palpate the external structures, the nasal bone, palpate the external nares for lesions, bumps, any pain or tenderness?
No.
Okay. I'm going to look at the outside. After I do that, I'm going to take my otoscope, which I already put a clean head on, and get down low, have her look up a little bit. Just tilt her head up, and you're going to push the tip of their nose up so you can look inside. What you're going to look for is the septum to see if it's deviated, which is not. You can appreciate the nasal mucosa, which is pink, and the turbinates, which are small, round, and pink, as they should be. Now you're going to do the same thing on the other side. Just get a nice Nice visual in there. Okay, everything's normal there. Now we're going to test cranial nerve number 1, the olfactory nerve. What I'm going to do is have her describe some common smells to me, so just close your eyes and tell me what you smell.
Coffee.
She said coffee, which is correct, and there's one more coming up. Keep your eyes closed. Tell me what you smell.
Cinnamon.
Excellent. She said cinnamon, which is correct. Cranial nerve number 1 is intact. Okay, so what we're going to do now is, I believe that concludes the nose, so we're going to move to the mouth. I'm going to take a nice look at her lips, which are nice and moist. There's no cracking, dryness, or scales. We're going to look at her teeth. Smile for me. Open your mouth a little bit. She has all of her teeth, and her gums look nice and pink. I'm going to take a tongue depressor and just take a look a little bit deeper. Stick your tongue out, say out. Okay, so I can see her uvula looks good, the pharynx looks good, tonsils look good, there's no exudate. Open it again. Soft and hard palate are good, buccal mucosa is pink. Lift your tongue up. And check under the tongue too. The floor of the mouth is looking good. Everything looks nice and healthy. Say ah. Okay, so the uvula elevates symmetrically on each side, which tests cranial nerve number 10, the vagus nerve. Close your mouth and stick your tongue out. Go side to side. Okay, hypoglossal nerve number 12 is intact. And if we want to test glossopharyngeal nerve number 9, we're going to do the gag reflex, but we don't want to do that because we don't want to induce vomiting. That's how normally you would do it. The next thing we're going to do is we're going to take a look at the neck. So the neck, going to visually inspect it to make sure that it's in alignment, everything looks normal. You can ask the patient a few questions if you want about them having pain. You're going to palpate the neck to ensure that there's no lesions or bumps or anything, asymmetry or pain. You can palpate the trachea at the midline here. You want to feel it. Is there any pain or tenderness?
No.
Anything? Okay. No abnormal lumps. To check the thyroid, you're going to go behind the patient. You're going to go right about here with your fingertips, and you're going to have the patient swallow. Okay, you can feel the thyroid a little bit there. You're going to oscillate the thyroid with the bell of the stethoscope for bruits. So hold your breath. Hold your breath. Excellent. No bruits there. What we're going to do now is we're going to check the 10 lymph nodes that we have to check. We're going to check for enlargement or anything abnormal, asymmetry, anything like that. So we're going to start with the preauricular, which is here, the postauricular, back here, the occipital, which are back here in the scalp. We have the tonsillar, which are right here, submandibular, submental, superior cervical, posterior cervical. The deep cervical chain, we actually have to displace the sternocleidomastoid to get to, and then the supraclavicular chain, which is right about where the collarbone meets the trapezius muscles. And last, for the neck, we're going to check cranial nerve 11, the spinal accessory. So I'm going to have you shrug your shoulders and push up against my hands. Boom, turn your head to the left, resist my hand. Turn to the right, resist. Cranial nerve number 11 is intact. The last thing we're going to do is the respiratory portion of the exam. So for this one, I'm just going to actually, can you just stand up a little bit and just kind of move your chair forward, get teeth? Okay, perfect. So what we're going to do here is I'm just going to first visually inspect her breathing, just to make sure she's not using any, excessive of the respiratory accessory muscles like the intercostals or the serratus. Turn to the right a little bit. I'm also going to observe from the back, just make sure that there's nothing abnormal. First, I'm going to check for, you can check for respiratory expansion to make sure that there's no asymmetry in breathing. So what you're going to do is you're going to do the apical, anterior, posterior, and lateral. So you're going to start just putting your hands like this and have them take a deep breath in and out. Go ahead. In and out. In and out. In and out. In and out. Any pain or tenderness or anything?
No.
Okay, so breathing is symmetrical in the back. You're going to do it in the front as well. Please face me here. Okay. If your patient's female, obviously you're going to have to be a little careful. Just let them know that you're just doing your job. Go ahead and breathe. Okay, again. Okay, I'm going to avoid some of the other areas because they're a little more personal, just pretending it is a real patient that I don't know. Go ahead. Okay. The next thing we're going to do is we're going to test for tactile fremitus. I'm going to have the patient say something while I assess with the ulnar surface of my hands. So we're going to start at the apices. Go ahead and say 99.
99.
Say 99.
99.
Again.
99. 99.
Again.
99.
Okay, now we're going to do the same thing in the back. Please turn to the side. Okay, so again, we're going to start at the top, take it from the top, move our hair forward, say it.
99.
Again.
99. 99. 99. 99. 99.
Okay, appears to be normal. Now we're going to palpate for any abnormalities, pain, tenderness, or any kind of bony projections that aren't normal. She's going to tell me if she feels any pain or anything, normal too. So just keep breathing, normal. Face forward, please. Same thing, and palpate. Keep breathing. Be careful if it's patient's a female, obviously. Okay. And now we're going to percuss. What we're listening for is whether the sounds are tympanic, hyperresonant, dull, so that we can assess the state of the lungs, if there's anything abnormal. So I'm going to start using this third finger with this third finger with the proximal joint. I'm going to tap. So that's the upper portions are pretty resonant. As you get lower, I'm going to avoid there. You can hear them kind of get a little bit duller. Okay, turn this way again, please. Now I'm going to do the back portion, which is a little bit easier. And you're going to do it in a ladder S shape. Okay, and the last thing we're going to do after percussion is auscultation. We're going to auscultate the lung fields to listen for any abnormal breath sounds. We just want to make sure everything's normal. So again, you're going to start here, and you're going to listen to one full breath each position. So go ahead and breathe in and out. 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 Those are nice breath sounds. In and out. Okay, turn and face me, please. Same thing in the front. I'm going to take a listen to the breath sounds. Go ahead. Go ahead. Again. Okay. I'm sorry. Again. One more time. Okay, if we want to, we can even listen to tracheal sounds. Go ahead. Those are usually the loudest. And then we will also inspect the anterior posterior to lateral ratio. So if we take a look at our patient's anterior to posterior plane, just keep breathing normal. The ratio should be 1 to 2 to the lateral plane. So anterior posterior to lateral is 1 to 2. And that concludes our exam. Thank you. And thank you.